All right, let's talk about meningitis. This is one of those diagnoses that every trainee needs to have locked down because when it shows up, things can go south fast. Getting the diagnosis and treatment right is absolutely critical. So let's get into it.
So picture this. You're in the ED, it's late, and a patient walks in with this classic triad: fever, headache, stiff neck. Right away, meningitis is at the top of your list. Your brain starts firing on all cylinders, right? Because you know every single minute counts. But as you're about to see, the next step isn't always so obvious.
And boom, here's the first big problem. You do the lumbar puncture, you send the CSF to the lab, and you're hoping for a quick answer from the gram stain. But guess what? In 95% of cases, it's going to come back negative. So you just can't hang your hat on that initial test to rule out a deadly bacterial infection. This is where you really have to be a clinician and rely on all the other clues.
Okay, so let's start at the most important fork in the road. Is this viral or is it bacterial? Because the answer to that one question changes absolutely everything you're about to do.
You can see the contrast right here. Viral meningitis, it's way more common, and patients usually do fine with just supportive care. But bacterial meningitis, that's a completely different beast. It's a true medical emergency. If you're slow to start antibiotics, you're risking severe brain damage or even death. So our #1 job is to sniff out those few really dangerous bacterial cases.
Now let's run through the viral culprits. Your history is going to be huge here. You need to ask what time of year is it, because enteroviruses and West Nile have their seasons. You ask about any history of similar episodes, which might make you think about HSV2. And here's a tricky one to remember. Varicella zoster, the shingles virus, can cause meningitis without any rash. That's a classic pitfall.
And on the bacterial side, these are your usual suspects. Strep pneumo is the big one, the most common cause out there. But for any patient over 50 or anyone with a weakened immune system, you have to be thinking about listeria. And if you've got a patient with other risk factors, say IV drug use, you've got to worry about Staph aureus from something like endocarditis.
All right, so you've done the lumbar puncture. This is it. This is the single most important test you're going to do for this patient. The CSF results are where you're going to find the answers you need to crack this case.
This table is basically your cheat sheet. Let's really zero in on the differences. For bacterial, you're going to see a much higher opening pressure and a sky-high white blood cell count. We're talking thousands of cells, and they're mostly neutrophils. Viral is usually a lower count, mostly lymphocytes. But here's the real kicker. Look at the glucose. Bacteria gobble up sugar, so if that CSF glucose is low, like under 40, that is a massive red flag for a bacterial cause.
And this number, this is why we don't mess around. Even when we do everything right, when we give the right antibiotics on time, about a quarter of patients with bacterial meningitis still die. 1 in 4. That's a really sobering thought, and it's what drives us to be so aggressive from the moment the patient hits the door.
But what happens when the CSF results are kind of murky? Maybe you see lymphocytes, but the patient is just way too sick for a simple virus. This is when you've got to think outside the box and consider some of the less common causes.
Tuberculous or TB meningitis is one you absolutely cannot afford to miss. The story is usually slower, developing over days or even weeks. And the classic finding is a meningitis that hangs out at the base of the brain, messing with the cranial nerves, especially cranial nerve 6. The CSF is tricky here too. It'll show lymphocytes, which can fool you into thinking it's viral, but the glucose will be super low.
And then you can see some really wild stuff. Look at this MRI. This is neurocysticercosis, which is a parasitic infection. The presentation is often dramatic, with seizures, and the imaging is pretty darn unmistakable. This is why asking about travel history is so important. It's much more common in places like Mexico, Central and South America, and parts of Asia. It's a great reminder that a good history can change everything. Okay, you've built your differential. You have a strong suspicion. Now it's go time. The next few moves you make are incredibly time-sensitive.
Now, the order of operations here is non-negotiable. First, get your blood cultures, always. Then, if your suspicion for bacterial meningitis is high, you start the empiric antibiotics and dexamethasone. Right then, do not, I repeat, do not wait for a CT scan or the LP. If the patient needs a CT, fine, get it, but the treatment has to be started first.
So let's talk about the steroids for a second. The data on this is really solid. Giving dexamethasone right with or even just before that first dose of antibiotics helps calm down the inflammation in the brain, and that improves outcomes. This is especially true for strep pneumo, which, remember, is the most common cause. Timing is everything here.
And what antibiotics are we starting? Well, for most younger adults, it's vancomycin plus ceftriaxone.
But here's a massive clinical pearl. For any patient over 50 or anyone who's immunocompromised, you have to add ampicillin. Why? You're adding it to cover for listeria. Forgetting that third drug in an older patient could be a fatal error.
Okay, we've gone through a ton of information. Let's boil it all down to the absolute must-know, high-yield points that you need to take with you on your next shift.
Here's the bottom line. Viral is common, but bacterial is what kills people. In the CSF, a ton of neutrophils and a low glucose screams bacterial until proven otherwise. Do not delay those antibiotics and steroids for anything. If your patient's over 50, you better add ampicillin for listeria. And don't forget the zebras, VZV without a rash, and TB in those slower cases with cranial nerve issues.
So I'll just leave you with this final thought. You get a CSF back, and you see it's mostly lymphocytes. It's easy to breathe a sigh of relief and say, oh, it's just a virus. But hold on. Could it be a really early bacterial infection before the neutrophils have shown up to the party? Could it be TB? Could it be a fungus? The point is, the investigation is never truly over. You always have to keep thinking.